introduce today's lecturers, Dr. Jennifer Furin and Dr. James Seddon. Jennifer Furin is an infectious disease physician and anthropologist who has dedicated her career to providing health care for the sick and poor around the world. Dr. Furin has worked with patients who have MDR-TB since 1995 and has treated hundreds of children with the disease. She currently leads the Capacity Building Task Force at the Sentinel Project on Pediatric Drug-Resistant Tuberculosis and serves as a regular consultant and strong advocate for children and families affected by this disease. Dr. James Seddon is an academic clinical lecturer in pediatric infectious diseases at Imperial College London. He divides his time between clinical work, research, and teaching. The clinical work takes place in St. Mary's Hospital and at Great Ormond Street Hospital and includes the care of children with complex infectious diseases as well as those with immune deficiencies. His major area of research is that of children with tuberculosis, specifically its drug-resistant form. I will now turn you over to Dr. Jennifer Furin. Thank you. And I believe that Dr. Jennifer Furin is unfortunately experiencing some technical difficulties. So, Dr. Seddon, would you be able to start off the presentation while we try to get back on?
Yeah, no, that's absolutely fine. Well, hello everyone, very much welcome to the webinar. So I'll just outline some of the objectives that we're hoping to convey to you over the next 45 minutes, hour or so. So the first objective is to illustrate the impact of a case of drug-resistant TB on a household, and then to discuss the epidemiology of drug-resistant TB in household contacts. After that, we're going to review the need for active case finding for household contacts for people with drug-resistant TB and what kind of strategies we might employ. Next phase will be to talk about preventive therapy regimens for children exposed to drug-resistant TB, and finally think a little bit about infection control. So we're going to start off with a case. So the case is a 46-year-old man who'd been diagnosed with MDR-TB after 10 months of symptoms, and he had failed already a first-line regimen. He had started hospitalized treatment and started with pyrazinamide, kanamycin, levofloxacin, ethionamide, and cycloserine after his drug susceptibility test showed that he was resistant to isoniazid, rifampicin, and ethambutol. After 3 months in the hospital, plans were beginning better, plans were being made for him to go home, and he was moving back to his family in a rural area. Healthcare centre had been found near him where his directly observed therapy could be given and his injectables given at that time, and he was going to be followed up once a month in the community centre. So just before he was about to leave though, one of the nurses at the health centre where he was going called the hospital and said she was worried about the family and that they were very poor and that she thought that there might be some risks for the family becoming infected with drug-resistant TB. So really, if you're in this clinic, and this is where we enter the participation, a couple of questions. So first question, what would you tell the nurse about the risk of developing MDR-TB amongst household members? So if you can click on one of these and we can see what people's answers are. Okay, so that's excellent. So everyone seems to have gone for option C, which is almost certainly the right one. So option 1 is not true, and MDR-TB is as transmissible as pan-susceptible. Then option B, saying everyone should be wearing masks or not sharing cups and things, is not really appropriate. And option D, although children under 5 and those with HIV are particularly susceptible, they're not the only ones and everyone is at risk. So option C, as most people got, is the correct answer. Okay, and then the second question, what additional action steps? I'll just finish this question, Jen. So number 2, what additional steps should be taken for this family? So people can read through that and take a minute or so to think about the questions. Okay, and again, I think people are kind of got the right idea. So sending a note home with the patient, asking them to bring the family. I mean, a lot of places do this kind of thing, and it is sort of somewhat effective, but we just know that a lot of cases will get missed if you rely on that. The patient should be sent home with a mask. Well, I mean, that's just not A, particularly effective, and B, is not really going to be implemented. And option D, to say that no additional steps are taking place is really missing an opportunity to carry out some contact tracing. So option C, saying that household evaluation assessment of contacts should be done, is really what we should be aiming for. Okay, Jen, I'll hand over to you now. Jen, are you able to continue from here?
Absolutely. I apologize, everyone, and thank you, Dr. Seddon, for getting started. So, you know, when we think about children with drug-resistant TB, we really need to think about things from a cascade perspective. So we have children all along the spectrum, and the sad fact of the matter is very few of them ever get to the end where they're cured of their MDR-TB. So children can be susceptible for things like HIV, malnutrition, etc. Children are exposed both in the household and outside of it. Many of the children who are exposed will become infected, and then a proportion of them will go on to develop disease. So it's important to see contact tracing and sort of active case finding as helping get more children into this cascade earlier. I think Dr. Seddon already mentioned this briefly, but been multiple studies that actually show that household contacts do become infected and sick with drug-resistant tuberculosis. There was a time period back in sort of the late 1990s and early 2000s when there was actually discussion that MDR-TB was not as transmissible as pan-susceptible disease, but multiple studies have shown that that's absolutely not the case, and we'd like to briefly review some of these here. There was a study done by Lucilea Teixeira in Brazil that found that 4% of MDR-TB household contacts developed active TB. This is a rate similar to that seen with pan-susceptible disease. I'd like to talk about Mercedes Becerra's findings in a little more detail, and then a study by Grandjean et al. Also found that the TB incidence in household contacts of MDR patients was 2,360 per 100,000 contact follow-up years, and these are really high numbers. So if we go on to look at a little more carefully the work done by Mercedes Becerra and her colleagues in Peru, you can see where they followed a number of household contacts of patients who were diagnosed with both MDR-TB and XDR-TB. And overall that they followed them for 4 years out, and overall that they found that there was an incidence of 1,624 active cases of TB per 100,000 patient years, and you know this would make it the highest burden country in the world if we actually looked at subgroups the same way the WHO looks at countries. You'll see a majority of those cases were found in the first year, but it's also interesting to note that the number of the incidence per 100,000 patient years was actually much higher in patients who had XDR-TB. And the reason for this, we think, is that, as many of you know, that XDR-TB is more challenging to treat, but also there tends to be a great lag in diagnosing this disease, particularly as access to secondary drug susceptibility testing is limited. So it's likely these patients were not on effective therapy, and the longer they were infectious in the home, the more likely they were to transmit disease. So moving on to a meta-analysis that was led by Sarita Shah, who's now at the CDC. She and her colleagues went back and looked at all the studies done on household contacts among patients with drug-resistant tuberculosis. So they looked at a total of 25 studies. The median number of contacts in each study was 111. And what they actually found was the pooled yield for active DRTB in these households was 7.8%, while 47.2% of the contacts were found to have evidence of latent TB. So again, these numbers are very high, and they point to you know, active contact tracing as a great way to identify cases and sort of increase the yield of finding sick children. She found 50% concordance with the exact same drug susceptibility pattern, and we'll talk about this in a minute. And then the majority of cases were detected with an error of source case identification. So the next couple of slides just look at the results from the Shaw meta-analysis, and you can see there's a wide range actually in the number of contacts who developed active TB, ranging anywhere from 0% to 29.1%, with the sort of median there at 7.8%. And just a comment that the reason these numbers vary so widely have to do with how household contacts were defined and the period of follow-up. So just so that people know that. And then the next slide actually shows latent TB infection. So these were patients that either had a positive skin test or an AGRA, although most of them were skin test findings. So these tell you the person was infected with TB. It doesn't tell you if it's drug sensitive or drug resistant, but given the high saturation of disease and spreading of bacilli in households, it's likely that these are people who were infected with drug resistant strains. I just want to briefly talk about this issue of concordance with drug susceptibility patterns. And so if you look at the Shaw data, you might say, well, gosh, only half of them had the same exact pattern as their household contacts. And so maybe they weren't infected in the household. But actually, when people went back and did genotypic matching of the strains, the numbers are much higher. So Jonathan Parr and his colleagues also in Lima, Peru, found that well, about a third of the patients had the exact same drug susceptibility pattern as their contacts. 90% of them actually had the same strain of drug-resistant tuberculosis. And again, there are a couple of reasons for this. You know, certainly the reliability of drug resistance testing, particularly the second-line drugs, can be called into question. But there is a phenomenon called resistance amplification that I'm sure many of you have heard about and that has been widely discussed, where patients who originally have MDR-TB strains but who don't receive drug susceptibility testing and are put through a series of empiric regimens can develop further resistance. And the picture I show you here is actually of 3 young siblings in Lima, Peru, all of whom had MDR-TB. They had the same strain, but their resistance patterns was different. The sister had resistance to INH and rifampin. The middle brother had resistance to INH, rifampin, pyrazinamide, ethambutol, streptomycin, and kanamycin because he'd received a number of empiric regimens. And then the third brother to the side had resistance to INH, rifampin, ethambutol, and pyrazinamide because he had been treated with a first-line regimen. So this case study was published, but it's a good example to remind us that, you know, even within households, while things may look different, the patients are infected with the same strain. So moving back to our case discussion of our poor patient here. So, you know, the National TB Program was concerned, and they went out and did a household evaluation. A community health actually went to the house to see this family. So she found that the family was living in a compound that had 3 small shacks and an outdoor latrine. So the patient himself shared one of the shacks with his wife, and they had 3 children, one who was 5½, one who was 8, and one who was 11. And the other shack was occupied by his sister and her husband, and they had twin sons, both aged 2. So again, this is pretty typical in many of the settings where we work, that this kind of household structure is there. So the nurse wanted to assess everyone. What she found is that she went to visit during her work hours, and this also happened to be the time that the older children were at school. So she wasn't able to see the older children. She asked the parents if they had any signs or symptoms of TB with a focus on cough, fever, and weight loss. And she was told no, but that one of the children did have asthma. This nurse was good, and she actually went to the other shack to talk about potential TB symptoms in that family. And what she found was that one of the twins, who was 2 years old, had diarrhea and wasn't gaining weight. So the nurse placed a skin test, a TST, on both of the children. She filled out her contact tracing form, gave the family information about TB to educate them about signs and symptoms, and she asked the twin boys to come back to the clinic in 48 hours to have their skin test read. So this leads us into our next series of questions. So the first is, what other information should the nurse have obtained? And you can see the different options there. I'll give you a few minutes to vote. Great. So everybody's in, and everyone is really focusing on answer A, which is correct. So, we need to think about the HIV status of the household members, information on anyone who's lived there in the past year and may have moved, as well as sleeping arrangements of the family. The other ones talk about animal exposures and water sources, but in this situation, probably not as important. It's key that we think about HIV status early in the process of contact tracing. Many of the household members, we will not know their HIV status at the time the contact tracing is done, and whether or not they're HIV positive will affect what you do. So it's actually good practice in routine contact tracing to be able to offer HIV counseling and testing on the spot. So moving on to the next question, which is, what steps could have been taken to improve the contact tracing process? And again, I'll give you a couple minutes to focus on the questions there. Great. So again, it looks like everyone's picked the correct answer, which is B. The nurse should return to the home to see the kids who were at school. She should go home to read the TST, and then they really should arrange for monthly visits, and the sick child should be referred. I will point out this looks nice and easy on paper, but if you think about the situation of many national TB programs, they're quite stretched in terms of human resources, and so having nurses go back to the household multiple times can be challenging. So we can move on then to the next slide. I just briefly want to talk about the desperate need we have for best practices for contact evaluation. Most household contact tracing is done as sort of an afterthought. NTPs and TB programs are very busy. They have limited resources, and doing this sort of falls to the bottom of the pile. What I always like to point out to people is that actually identifying cases early and being able to prevent them will save time in the future. But we do understand problems with human resource limitations. There's also concerns about how to find a household. How do we focus on everyone and not just the most vulnerable, which people would agree are the under 5s, and then the HIV infected. And then, as I mentioned, there's lack of careful follow-up. So in terms of looking at household definitions, I think there are many definitions out there. The definitions used are one of the reasons why we see such different results in household contact studies. The World Health Organization defines a household as a person who shares the same enclosed living space for one or more nights, or for frequent or extended periods during the day with the index during the 3 months prior to commencement of treatment. And there are certainly issues with this that we could talk about extensively, but I think this is a definition that can be a useful place to start from. And again, to point out, the WHO recommends contact evaluation for all household contacts of drug-resistant TB patients. So this is just a study by Van Wyck et al. That showed, depending on the definition you use for a household, you can get very different results. So the group looked at 2 definitions. So a household was all dwellings on the same plot of land that share the same residential address. And the second definition was a person or a group of unrelated persons who live together in the same dwelling unit, shared housekeeping arrangements, and who have same eating arrangements. So they got a very different yield depending on the results. And I just think it's important for programs to be aware that strict definitions generally underestimate or underfind household contacts, and you really need to think about the unique cultural settings and household settings in your community. I just wanted to focus briefly on the age-related risk. I think most of us know and have seen the epidemiology that shows that the highest risk children are those who are under the age of 5 and those with HIV infection. And we'll take a look at some work from Ben Murray and colleagues. But I would like to point out that older children between the ages of 5 and 14 have actually been shown to have rates of MDR-TB similar to those seen in children under the age of 5, even in the absence of HIV infection. And this data actually came from a household contact study done in Pakistan, where 7.8% of the children who were over the age of 5 and not HIV infected ended up becoming sick with TB versus 6.5% of the younger children, and HIV prevalence was very low in this community. One important note from Farhana Amanullah's study, which we'll talk about a little bit, is that there may actually be more older children than there are under the age of 5. So in terms of actual numbers, focusing on children over the age of 5 may yield a higher number of cases simply because more of the population is over the age of 5. And I always like to make sure that we put a plug in for adolescents. So adolescents are defined by the WHO as those between ages of 10 to 19. For the purposes of TB programs, we tend to treat anyone who's over the age of 15 as an adult patient, but there's some interesting data coming out of 2 MSF projects that actually show that adolescents have worse outcomes from MDR-TB when compared with children or adults. And, you know, many of us who know and love adolescents probably chalk that up to problems with adherence. But the data from Petra Isakidis and then from Sizulu Moyo actually show a substantial number of the adolescents are dying early in the course of therapy, which points to the fact that they're not being diagnosed. So keep adolescents in mind as well. This is just a graph from Ben Murray's work that was published in 2004 that looks at both pulmonary TB and disseminated TB. You see the nice peak in sort of the under 1s and then the kids under 2 as well as 2 to 5. But if you'll note again, there's a peak of pulmonary TB in the older age group of 10 to 15. So all of this is to say that while we tend to focus on the under 5s and the HIV-infected children in the household, actually all members in the household are at risk. So I've mentioned Farhana Amanullah's study, and I'd like to talk about it just a little bit more briefly here, simply because it was an excellent study with really interesting results. So Dr. Amanullah and her colleagues in Pakistan looked at all patients who were diagnosed with MDR-TB at a large referral center in Pakistan and used those identified patients to then go out and perform contact evaluation. So they did multiple visits over the period of a year, and they did a lot of work with community health workers and home visits. So among 133 children under the age of 15 in 40 households, 7.5% had TB disease. So again, it's a relatively high number, and as I pointed out earlier, you know, the numbers were equal between the under 5s and the over 5s. So I'm going to hand over to Dr. Seddon now to talk some more about contact tracing and then specifically some of the work that he and his colleagues have done in South Africa. So James?
Cheers, Jen. So, I mean, I think that hopefully we've convinced everyone that going into the house of adults who have drug-resistant TB, looking around, evaluating children, trying to screen for TB disease and treating those early and promptly, which have the greatest chance of success, and then identifying children who are high risk of infection, high risk of progressing to disease and giving them some kind of preventive therapy. Those are all concepts which hopefully we've convinced you would be a high yield activity. But the bottom line is it doesn't happen in many places, and that's for a number of reasons, and one of the main ones is that often it's a low priority for TB programs. In programs with limited resources, limited staff, really treating the active cases is the priority, and dealing with well children out in communities, in people's households, is not the biggest priority. The other thing that often happens with contact tracing is it only happens once, and that's better than no times, but if it's only done once, you know, children are at school, they're out, they're with their friends, they might be somewhere else, and so often you miss patients if you just go in once. And then in many programs, contact tracing isn't done by home visits, and I think there are lots of studies which have shown that actually going into people's houses physically will identify far more children. But what happens in reality is that in most places, the adult source case is told or is asked in clinic, do you have any children in your house? Is anyone unwell? If you do, bring them up to the clinic and we'll evaluate them here. And that is the standard of care in many places. And really that will just not identify as many patients as other systems. So this is a study, a small study a group of us did in South Africa, and this is the tip of South Africa, tip of Africa in Cape Town. And the area of Cape Town is divided to 8 health districts. And one of them, Khayelitsha, which is the red one that the arrow is pointing to, has a very high incidence of HIV and a high incidence of MDR-TB. And the Médecins Sans Frontières, the MSF team, have been working in Khayelitsha for a number of years trying to organise a decentralised system of care so that care is organised as close to the patients as possible. It's still not actually in their homes, but it's not hospital-based care. The other 7 sub-districts still often rely on hospital-based care, and particularly for children, the other 7 districts refer their child contacts and their children with TB to Tigerberg Children's Hospital, which is where the other arrow is. So in Khayelitsha, once a month, a satellite clinic would go out and evaluate children within Khayelitsha. And so this is just a study over 1 year, 12 months. This is all the patients diagnosed with MDR-TB in all of those 8 provinces. And what you see is that they're about 35, half men, half women, half HIV, half smear positive. And the cases are distributed amongst the 8 sub-districts. And if you were in most households in that area, and people have done lots of surveys and questionnaires and things, you'd expect to see 1 or 2 children per household. So you'd expect to see 1 or 2 children per index case, per source case. And we know that in Khayelitsha, there were, in that period of time, there were about 190 source cases. So if you had 1 contact, 1 child per source case, you'd expect over that period of time to see about 190 children. If there were 2 children per source case, 380, and 3, 570. And in this other subject, same principle, there were just over 1,000 source cases in that period. If you saw 1 child per source case, it would be this number, 2 and 3. That's how many you'd expect to see if that was taking place. What actually happened was that in Khayelitsha, over that period, 38 children were seen, and 115 children were seen from the other sub-districts, which means that of all the source cases in Khayelitsha, 190 of them, only 31 or 16% led to a child being identified. And this is pretty terrible, but it's a bit less terrible than the other sub-districts where it was lower, and this was significantly different. And also the time delay between the adult being started on treatment and the child being seen was shorter in the decentralised model than the others. Now, I'm not saying this is the answer because actually it was pretty poor in Khayelitsha as well, but it does show that if you go into people's communities and do this kind of activity there, you're likely to get better yields. And then when people are asked why did they not come to their appointments, why did they not attend the hospital appointments that children were supposed to come to, and there were a number of challenges, and I think it's really important to try and think about why are these challenges. So it's difficult to get to. The hospital is difficult to get to because they don't have money. Often the weather becomes problematic. Takes 2 or 3 different taxi rides or bus rides to get there. Sometimes people in the clinic be a bit nasty to you or give you unpleasant sort of experiences. And then some people feel that their children are at risk by sitting all day in clinics with lots of adults who are coughing and spluttering. Sometimes people are very concerned about their children, and some people are just, don't have a lot of sympathy for the whole system. And this is when we did another study. It's a slightly different study where we divided 50 children who had been referred to their appointment to be seen. Sorry, I can't get this pointer to work. Let me just get rid of that. I'll try and get that going again. Anyway, I'll just talk you through it. So there were 50 children who did not attend their appointments, who had been identified and referred at the clinic level, and 50 children who had attended their appointments. And what you see is that when the mother was the source case, children were much less likely to attend, and this probably tells us that the mothers were either in hospital or sick and didn't bring the children. Or if you look at the bottom ring, you're seeing that if they have to travel a long way, or if they have to take multiple minibuses, or if it costs a lot, again, people are much less likely to attend their appointments. In terms of kind of perceptions, if you look at this group on the left who don't attend and the group on the right who do attend, the factors that are different are a number of perceptual things, but one of them is if they think their child's at risk of getting MDR-TB while they're waiting, that they might be less likely to attend. So I'm not going into too much detail for this, but it's just really important to think about why do people attend their appointments? Why do people come for these kind of follow-ups? And is there anything we can do as health professionals to either improve that or to actually do the home visits in the first place, which mitigate all of this anyway? The next thing that I think it's worth talking about is how we do reverse contact tracing. Now, the traditional model, which we've talked about with all the studies that Jen has talked about, is that you find an adult who's got drug-resistant TB, and you go into their home, or you ask them questionnaires, and you try and identify children, either who have disease already, or who are infected and have a high risk of getting disease. And that's the traditional kind of concept of contact tracing. However, we should also be thinking, where has this child got their TB from? Because if a child has TB, someone else will have given it to them, and most likely is someone in their household. So we should, whenever we diagnose a child with TB, we should be thinking, where have they got this TB from? And we should be instigating a contact tracing or reverse contact tracing investigation to try and figure this out. This study was done quite a long time ago in Cape Town, where Simon Scarf looked at all the mothers of children diagnosed for TB. So there were 163 children diagnosed with TB, and they did chest x-rays on all the mothers, and then they did sputum culture on those mothers with suspicious chest x-rays. And they found that 10% of these mothers had TB, or had likely TB. And basically, this meant that this is a very effective screening strategy. Another study done in the US showed a kind of similar thing, so that if only of 60 children, 59 children who were being treated for TB, only 12% of those were infectious and causing a problem. However, if you look at the caregivers who brought those children to their appointments, 17% of those were infectious. So if you're worried about infection risk, it's not necessarily the child, it might well be the adult who's bringing them. And if you have a child who's diagnosed with TB, if you look very closely at the caregivers and the people in their family, that has an incredibly high yield of identifying the person who gave them. So it's much more cost effective than just investigating other people. So I'll hand you back to Jen to continue with the case.
Great, and there was actually a question I wanted to address that asked about what type of screening tools were used for the monthly screening in Pakistan, and I'm certainly happy to provide more follow-up on that, but in general there were special tools designed for contact tracing and doing the monthly evaluation. In general, what we found is the contact tracing tools used for adults don't tend to work as well in children. They tend to have very different symptoms. So asking if a 5-year-old has cough, fever, or weight loss is sometimes very low yield. So Dr. Amanullah and her colleagues actually developed a special symptom-based screening. They were monitoring weight and height and looking for children who were falling off their growth curve. And so they used very designed and specialized tools. And one of the things we're actually working on in the Sentinel project right now for anyone who's interested in is developing better tools for household contact tracing among children who have a household contact with MDR-TB. So please feel free to be in touch with me if you're interested in hearing more about that. So going back to the case discussion, the mother of the twin boys brought the boys to the clinic for their follow-up TSTs. The nurse read them and both the TSTs were negative. So she told the mother the children had not been exposed to TB and referred the children to the Maternal Child Health Clinic to be seen for the diarrhea and weight loss, and the child got ORS and was dewormed. So moving on to some other questions, what should have been done for the child with diarrhea? Here are some possible responses in terms of what we needed to do for the diarrhea. Great. So most people picked C, that the child should have undergone HIV testing and, depending on the results, referred to a TB clinician to rule out active TB. You know, some people would say that that's actually not correct, that the child should have been evaluated by a TB clinician no matter what. And so I actually think B is the answer that we were hoping for, that whether or not this child has HIV, this is a 2-year-old who's at very high risk, regardless of his HIV status, for developing disseminated disease. So that child, because he has a household contact with MDR-TB and he has symptoms including weight loss and GI symptoms, somebody needs to make sure this child does not have a TB. An HIV test is always a good answer, but I think the child needs to be seen regardless of the HIV test. So what should have been done for the 2-year-old who didn't have any symptoms? So this is a 2-year-old with no symptoms, negative TST. So there are, again, a number of answers here. So HIV testing, clinical assessment, chest x-ray, preventive therapy only if positive and active disease ruled out. HIV testing, clinical assessment, radiograph, and preventive therapy no matter what the HIV test, as long as active disease is ruled out. HIV testing, radiograph, and preventive therapy only if the HIV test is negative. No additional testing. So it seems like we have a broad range of answers here, and the correct answer is B. That this is a 2-year-old child who's at very high risk for having for developing active TB and is at risk for disseminated and severe forms of disease. The child should definitely undergo HIV testing and clinical assessment. But these are children that we recommend preventive therapy for regardless of their HIV test. And Dr. Seddon is going to talk a lot more about preventive therapy in children who are household contacts and what we recommend for them. And then the final question is what should have been done for the 5-and-a-half-year-old child. So again, they're the similar answers. So this child is 5-and-a-half. Okay, so this is actually an example we're trying to put up here to illustrate some of the differences. So this child is 5-and-a-half, and this is part of the real-world frustration of having an age cutoff for preventive therapy. So this child should not receive preventive therapy unless they're HIV infected. So the correct answer, based on what we know now, is actually A. So for children who are under 5, they get prophylaxis regardless of their HIV status. Children who are over 5 get preventive therapy if they're HIV infected based on the current recommendation. So thank you. So I'm going to hand over to Dr. Seddon to talk then about the utility of the TST and what we do with contacts and their evaluation. So James, back to you.
That's fine. And just to say that, I mean, TST can be a useful tool in people's hands if they are placed correctly, read correctly, and the person who's interpreting them understands that there are limitations to the sensitivity and specificity. But the bottom line is they are flawed tests, and they don't identify all the children who are at risk, and they do miss some. And this is a systematic review and meta-analysis by Anna Mendelikis, which looked at the sensitivity of TST in response to confirmed disease. So this is not to look for infection, because it's impossible to look for infection. This is to do with confirmed disease. And you see that it's sort of it's under 80%, so you're missing 20% of children with absolutely confirmed disease. And so that just says to me that this is not a perfect test. It may well be less than 80% for children who have TB infection. And the WHO, these are the recommended guidance from the WHO, which came out a few weeks ago for drug-susceptible TB, and really intellectually there's no reason why this should be any different for drug-resistant. So I'm going to move over to this side. So if they're under 5, so if they're a close contact of someone who's got smear-positive TB, if they're under 5, if they're symptomatic, you think about disease. If they're if they're over 5, and they're symptomatic, you think about disease. So either way, you think about disease if they're symptomatic. But if they're young, you give them preventive therapy, and if they're older and they're HIV negative, you don't. So it's quite a simple algorithm. Basically, under 5, evaluate for disease. If they're well, give them preventive therapy. If they're over 5, evaluate disease. If they are well, you don't unless they've got HIV. And this is an algorithm, I don't know how well this sort of projects on this, but this is an algorithm that just is one way of thinking about how to manage children exposed to drug-resistant TB. So they've been exposed to a source case with drug-resistant TB. Does the child have TB disease? That's the first question. If they do, you start treatment for that. and we talked about in the previous webinar. Then you think, do they have infection? And yes, maybe use the TST or IGRA perhaps if you want to and if you have that tool. But think about how severe is the disease in the source case, how intense was the contact, how long was the contact. Then think if they are at high risk of being infected, what is their risk of disease progression? So think, are they young, do they have HIV, do they have other problems? And then if you think, well, they're at high risk of infection and they're at high risk of going on to disease, what is the chance they have an MDR strain? So then you think, what's the concordance between the source case and the child? And then you make a decision whether to give MDR or drug-susceptible preventive therapy if you're going to do that. And just a couple of notes about this. So if you're using GeneXpert and the sample in the source case come back as rifampicin resistant, that doesn't mean rifampicin monoresistant, it means rifampicin resistant. And in the most cases, this means MDR. So if you have rifampicin resistance coming up in GeneXpert, assume it's MTR, unless you get it confirmed as rifampicin monoresistant and susceptible to isoniazid by LPA or DST. Generally, MDR preventive therapy, it really depends on the program and the country whether anyone will actually give any kind of treatment, and you can follow that. But options include fluoroquinolone and high-dose isoniazid, fluoroquinolone, high NH and ethambutol, fluoroquinolone, ethambutol, high-dose INH on its own, fluoroquinolone on its own, or nothing. So there are a number of options, and it depends a bit on the source cases, DST, and what the program suggests. And this is an algorithm we came up with. This is out of the Sentinel Project Field Guide. So you have contact with an infectious source case, you have the history examination. If you think they have TB, go down the actual disease line. If they're actually clinically well, if they're older than 5 and HIV unaffected, reassure them. If they're younger than 5 or they're HIV infected at any age, you record them in the register, and then depending on the drug susceptibility pattern of the source case, you give them different regimens. So if they're isoniazid monoresistant, but they're susceptible to rifampicin, you can give them rifampicin. If they are resistant to rifampicin, but susceptible to isoniazid, you can give them isoniazid. If they are MDR and susceptible to ofloxacin, then you can give a preventive therapy regimen with a fluoroquinolone in it. And if they are MDR and resistant to ofloxacin, well, you haven't got many options here, and maybe giving high-dose isoniazid might be an option, or just close observation. So this is not saying this is the right way to go, this is saying this is a way to go. And there are lots of guidelines. There's WHO guidelines, there's British guidelines, there's ECDC guidelines, American guidelines, and the bottom line is there isn't much evidence, and we haven't got great guidance on how to manage these children. There are 4 studies or 5 studies that have been done, 4 that have any results that are useful, to look at how we manage child contact. So one study was done in Cape Town a number of years ago. It took 61 children who were infected and 44 who hadn't, and effectively the ones who were given preventive therapy had a significantly reduced risk of getting disease. And that preventive therapy was a mixture of isoniazid, high-dose pyrazinamide, ethambutol, and some got fluoroquinolones. The next study was done in Brazil, and this had a whole load of MDR-TB contacts, and some of them were just given isoniazid and some of them weren't, and really the isoniazid didn't seem to do very much. There was an interesting outbreak in Micronesia, which you can see from my little map there is just north of Australia, and the CDC helped out with an investigation of 5 MDR-TB patients, and they did massive contact investigation, identified over 200 contacts. They found 15 who had disease, and then they decided that 119 had TB infection. They used TST to make a decision about preventive therapy, and a number of them didn't want preventive therapy. And really, all the ones who were given preventive therapy based on fluoroquinolones, none of those patients got TB. But a number of those who didn't get preventive therapy developed disease. So again, it's not conclusive, it's not a randomized controlled trial, but it does give some suggestion that preventive therapy might have a role. This is a study I was involved in a couple of years ago. We recruited 180 odd children in Cape Town. They were young, only about half had positive TST, so we were treating children whether they had a positive TST or not based on contact history. About 5% were HIV positive, and we gave 6 months of high-dose isoniazid, ethambutol, and ofloxacin. And this is just to say that this regimen was pretty safe, so that we saw very, very few severe side effects, and most of these side effects were associated with mistakes in the dosing. And if you look at the outcome, so over 200 patient years of observation time, one kid died, which was thought to be sudden infant death syndrome, nothing to do with TB, and 6 children developed TB. And so when we look, and I'll move on now, if we look at the risk factors for having poor outcomes, so either death or TB, if you're less than 12 months, 5 children developed these poor outcomes, and in 40 odd years of observation, that's 114 poor outcomes per 1,000 years. If you look in the ones older than 12 months, it was only 11 incidents per 1,000 years. So there's an odds ratio, a rate ratio of 10 times as more likely to have a poor outcome if you're less than 1 than if you're over 1. Similarly, if you are HIV positive, you're 10 times as likely to have a poor outcome as if you're not HIV positive. And then what I thought was interesting and actually quite compelling for evidence to say that preventive therapy might have a role is if you actually took your drugs, over 80% of drugs took, only 2 children had these poor outcomes. Whereas if you don't take the drugs, many more did. So you're 7.5 times more likely to have a poor outcome if you don't take your drugs than if you do. And this suggests to me the drugs are doing something. So I'll hand you back to Jen, who will finish up the story and finish up the rest of the presentation.
Great, and I just want to briefly touch on a question that was asked from the audience about RNA microarrays and their role in potentially diagnosing TB in children. So this is actually an interesting technology that's based not on looking at sputum, but at host blood, at sort of the transcriptional signals that happen in children when there's active M. tuberculosis around. So it's an alternative method. In the experimental study, it showed a relatively high sensitivity and specificity. And so I think there's promise for this in the future as it's refined and could offer us another diagnostic potential. Some of the methods for running it is a little bit more complicated. The blood has to be collected in sort of special tubes and stored in a certain way. But I think all of us are on the lookout for better diagnostic tests in children, and it is good to know about host blood and transcriptional signals that are being looked at by other groups. So thank you for bringing that up. So back to the case discussion. So the little boy with diarrhea, he continued to lose weight, and he was eventually hospitalized with diarrhea and wasting. He did undergo an HIV test at that time and was had an extensive workup at a charity hospital. The HIV test was positive, and he was found to have gastrointestinal MDR-TB with the same resistance pattern as his uncle. And so he was also started on MDR-TB therapy. Because of the expense for the household, the mother had to get a job as a cleaning woman, and she put her healthy twin in creche or daycare, and she'd like to place the sick son in creche when he is out of the hospital, but she's been told he can't come to the creche because he'll spread MDR-TB to other children. So the question here is, what is the most important infection control measure that should be taken to prevent this child from spreading MDR-TB to other children in the creche? And we have a number of answers here. And it looks like everyone is thinking about how to keep this child from infecting other children. So we have several answers here. And I think we're sort of split a little bit between making sure the child has adequate support to adhere to his MDR-TB treatment and also noting that the risk is very low since the child has gastrointestinal TB and thus is less likely to infect others. I think both of these are correct, although I will point out some of my friends with toddlers tell me their diarrhea can be explosive and aerosolized, in fact, at times. So it's just something to keep in mind. So moving back quickly to the end of the lecture, I'd like to just briefly talk about infection control issues in the household and the community, particularly when there are children with MDR-TB running around. So, infection control for children with drug-resistant TB should really always include reverse contact tracing, as mentioned by Dr. Seddon. I think there are general infection control principles we can talk about in the household, but then also special infection control principles that adhere to children. But really the goal of infection control is to maximize safety while minimizing stigma. Again, just to point out that most transmission of MDR-TB and TB occurs prior to diagnosis and initiation of therapy, and we know that even starting someone on therapy for a few days decreases the risk of transmission. So when we're talking about household and community-based infection control, we want to, again, educate the community and avoid stigma. As long as the person is on therapy, they have a very low risk of transmitting, and I'll show you why we think that is in the next slide. Natural ventilation is great, and then having patients spend time outside. So we often talk about that. We think that once a patient is on therapy for MDR, even in the setting of positive smears and cultures, they're less likely to transmit. And this is a slide and some data from Ed Nardell and his colleagues that looks at the size of droplets and what happens when someone coughs a droplet in the air. It sort of desiccates and dehydrates. So the antibiotic concentration in that droplet nuclei goes way up. So that's why we think even being on therapy for a couple days is helpful. We often talk about infection control in the household, but I'd like to point out that most of our patients, or many of our patients, live in very poor households. This is some interesting work that was done by some colleagues in a slum in Mumbai that looked at infection control in the household in 29 households. And what they found is that early detection was the most important, but they also focused on using windows and fans and outdoor times. And it's just important because it can be challenging to think about infection control when we have patients who live in crowded and difficult circumstances, but very basic things may help. You know, these are just some pictures I have, and also from the internet. You know, children co-sleeping can be a risk if they're inside in a dark, cramped room, but outside is generally better for children. So when we look at infection control issues specifically for children and not just community-based, we know that children usually have a much lower bacillary burden than adults, and they're much less likely to transmit TB. And you know, this fact sort of led to a very perverse situation where children were often left out of TB control when it was focused only on the public health approach. They're also more likely to have extrapulmonary TB, and for this reason less likely to transmit. And we know that isolating children, forcing them to wear masks, keeping them home from school and other activities is very damaging from a developmental and emotional point of view. So really when thinking about infection control in children, we know that they're low risk to transmit and that isolating them can be very damaging. So we usually recommend that children be allowed to go back to school and attend school, and to join in the activities that are normal for children. You know, I hesitate to say the risk is zero because nothing is ever 100 or 0 in medicine, but children are very low likelihood to transmit TB and MDR-TB and should be encouraged to stay on appropriate therapy and to re-engage in the community in a way that's welcoming and warm for them. So just to summarize briefly the conclusions, we know that drug-resistant tuberculosis affects multiple members of the family, and that rates of transmission are similar to those seen for pan-susceptible disease based on a number of studies that we reviewed. We also know that household contact tracing can be a high-yield procedure for persons exposed to DRTB. And that contact tracing procedures really need to be strengthened to include multiple visits, extended follow-up, and then special screening mechanisms for children who often have atypical signs and symptoms. We know that preventive therapy for DRTB in the household has been shown to be beneficial in a small number of observational studies. And I would just like to mention there is ongoing planning for looking at a randomized trial of preventive therapy among patients with who are household contacts of DRTB. So be on the lookout for this in the future. Infection control measures can be helpful and can be implemented at home and in the community, things like opening doors, opening windows, encouraging kids to play outside. But we really need to be very mindful of not, you know, frightening everyone. Children are relatively low risk, and the stigma of being isolated, not being able to attend school or crash or play with their friends can be quite damaging. So it's always important to maximize safety, but again, minimize stigma and the emotional impact on children. You know, this sort of ends the formal part. I know Dr. Seddon and I went through some things very quickly in the interest of covering a lot of material in a relatively short period of time. So if there are questions, you know, we'll certainly wait for those to come up. I see a comment from someone in the audience mentioning that, children with HIV may also be a lower risk for transmission of TB because of low bacillary burden and extrapulmonary disease. And then another comment regarding the RNA microarrays, that yes, this is potentially an interesting technology, and we're all on board with interesting technologies, but we do need to emphasize that these things need to be carefully assessed and validated in clinical trials before drawing conclusions. I'm afraid in TB diagnostics we don't have a magic tool yet, and I certainly wouldn't want to overemphasize one tool over the other, but I think it is nice to see some development on the horizon and to be aware of what's out there and watch as future trials take place so that we can ultimately do a better job diagnosing children. So, Dr. Seddon, I don't know if you have any final questions or comments as we're waiting to hear from the group, but thank you everyone for your attention, and I'll turn you over to Dr. Seddon.
No, I've got nothing else really to add. Just to really emphasise on everyone that really this is the idea of doing household contact tracing to identify vulnerable children is a really high yield strategy, and I think we should be doing far more of it wherever people are working.
And I guess the other thing I would sort of add as my last comment is we often talk about the household as the place to go, but there have been outbreaks reported in other places where children spend a large amount of time, including daycare. I know of several outbreaks in which there was a creche or a daycare provider who actually had TB, and ended up infecting several of the children who became sick. And then we do think about school for the older children. So, we focus on the household because that's where most children do spend a majority of their time. But, it's important to think about other congregate settings for children, such as creche, orphanages. And usually what happens there, it's not that a child gets sick and spreads the disease, but that a provider in those settings, a teacher, a provider at creche, or someone who's working at an orphanage gets sick and spreads disease to the children there. So focus on the household, but also think about other congregate settings for children. I also see there's a question now for Dr. Seddon regarding the 3-drug preventive therapy, and is it recommended in Africa? So James, I'll hand that over to you.
Okay, we've only got one minute left, but I will just say that unfortunately no, that this is not a widely employed strategy. It's only really used in certain areas in South Africa. I think we need a better evidence base before we can say that this should be used extensively throughout the world, and we are hoping to carry out a trial to look at this soon. So I'll hand back to Evgenia.
Thank you. I'd like to really sincerely thank our lecturers and our participants for this very interesting webinar, for great questions. And as mentioned, you will be able to view the recorded webinar if you had any issues with the connection, and related materials also on the MDR-TB Training Network website.